All right, so good evening, everyone, and thank you for coming. Welcome to the 2022 NJSP spring meeting. We appreciate you all being with us. I know there are going to be more people joining the meeting as we go through. By way of introduction, I am Valerie Fitzhugh, and I am proud to be the president of the New Jersey Society of Pathologists, and I couldn't be happier to work with such a great group of people. Hopefully we'll be able to come back in person soon. I was really hoping to do this one in person, but COVID's still being a little bit wonky, so I think it's better and safe for us to all be doing this virtually. I am so glad that you are all able to join us. I hope you learn a lot tonight. We have a great meeting and a great lineup, and I will turn it over to Dr. Fife to introduce our speaker. Dr. Fife.
Thank you so much, Dr. Fitzhugh. May I share my screen for 1 second here?
I think you should be able to.
Okay. Hopefully you can see me. Dr. Konstantinos really has an international reputation in this area of dermatopathology and soft tissue pathology. He's lectured all over the world. He's also been all over the world and trained all over the UK, Australia. I'm very jealous reading your CV. Australia, the UK, coming from Greece Medical School. He's doing research, or had been when he was at Dartmouth, I assume, doing other things now that he's at Memorial Sloan Kettering, studying nevogenesis and melanogenesis, melanoma in particular. And he's going to talk with us today about nevus, melanoma, or something else, mesenchymal tumors with melanocytic differentiation. I just want to give also a shout out to many of our people who did presentations for our Case of the Month series. We had malakoplakia of the GI tract. We've had a peptic ulcer involving the liver, adenoid cystic carcinoma of the breast, extranodal marginal zone lymphoma of MALT in a gastric bypass specimen, undifferentiated uterine sarcomas, urachal mucinous cystadenoma. And, I hope we keep up the interesting work and leave us, and maybe Dr. Konstantinos will give us a lot of input into maybe showing some soft tissue tumors here on our Case of the Month. And I'm just so excited to have you. I'm so glad you were able to accept our invitation, even with other competing things going on. And I do know that our Vice President Raj really wanted to be here to introduce you, but he really had conflicting interests with the graduation of his own. So without further ado, thank you so much, Dr. Linas.
Well, thank you very much for the kind invitation. Let me share my screen. All right. Let's see if I can record that. Okay. I cannot record, but I assume it will be recorded, so we can make it available to all members of our community.
Yes, it's being recorded.
And I'll start, and then I'll turn off the camera so you can concentrate on the slides, and then I will reappear for the questions and answers. So I wear two hats. I am a dermatopathologist and a bone and soft tissue pathologist. And after spending quite a few years in Dartmouth, I recently joined Memorial Sloan Kettering, so I'm very close to you. And what I'm going to talk is entities that they are at the crossroad between melanocytic tumors of melanocytic differentiation, that they are mesenchymal, but they could actually be misdiagnosed as something different, like melanoma or nevic or other entities. And the first part of the talk will be about entities that they have true melanocytic differentiation, but they are mesenchymal neoplasms. And the second part of the talk would be entities that they are S100 SOX10 positive, with negative or more specific melanocytic markers, but still they can actually be misdiagnosed as melanoma or something else that can lead to pretty disastrous consequences for the patient. All right, let me stop this. All right. All right. So I have no relevant financial disclosures. There's a lot of things that we have. I'm going to talk, and you can see all these different entities that you'd be surprised how actually many entities they come into the differential. Of course, all of them are rare. Some of them are very, very rare. Some of them you will encounter them as a pathologist in your career at some point. And the first one is the so-called malignant melanotic nerve sheath tumor. So you are familiar with that, with the terminology of melanotic schwannoma. The terminology malignant melanotic nerve sheath tumor is a new terminology that has been, it is in the new WHO 2020 bone and soft tissue, but still the term melanotic schwannoma or pseudomonas melanotic schwannoma, etc., are still acceptable. But the main name is now malignant melanotic nerve sheath tumor. So what is it? And I'm going to use melanotic schwannoma because it's easier to say it. It is a rare tumor of putative neural crest origin. And where do we actually see them? We actually see them most often in the paraspinal nerve roots and the gastrointestinal tract. That's the most common locations. And as you know, it has an association with other stigmata of carnate complex. And people who have carnate complex, they have skin pigmentary abnormalities. They can get cardiac myxomas. So that's very important to diagnose them early because they can actually die suddenly because of the cardiac myxomas. And of course, they get various endocrine tumors or endocrine hyperactivity. And these patients, they have germline mutations in the PRKAR1A gene. Now, the patients who get melanotic schwannoma, it raises the concern for malignancy because they can be actually multifocal. And about 88% of patients with carnate complex, they actually will develop melanotic schwannoma. So what is this, the cell of origin? The answer is we don't know. It has hybrid light microscopic and ultrastructural features of Schwann cells and melanocytes. So it's a kind of a hybrid tumor. But the most important thing is that it has a very unpredictable behavior. So it can give up to 1/4, it can give metastasis, including patients who have histologically benign appearing tumors. And we're going to talk a little bit about this. So that was the rationale for the new WHO name that we were calling a melanotic schwannoma, but these tumors, they actually metastasize in 25% of the patients. How come we call it schwannoma? And it was a very legitimate argument. So hence the change of the name per the new WHO. So this is a classic case of melanotic schwannoma. I hope you see my arrow. So it typically grows in a multinodular fashion. It has kind of a general circumscribed masses that they can be quite infiltrative into the fibroadipose tissue. And they have this fascicular growth pattern. And there is a lot of intermingled melanophages. All the cells can have intracytoplasmic melanin. So that's why you can imagine, that's why this tumor can be actually misinterpreted as some kind of melanoma. If you go high power, actually the cells are pretty bland. You have this kind of spindle to ovoid pattern with intranuclear inclusions. And then of course you have a lot of melanin in between or intracytoplasmic melanin. But sometimes the tumor can have very epithelioid morphology, who kind of resembles a melanoma. So if you show me the right picture and you told me this is a picture from melanoma, I would say, yeah, sure, of course. So everything is context, but that's why it's very important to very thoroughly sample this tumor, because if you thoroughly sample, you're going to see areas that look more classic for melanotic schwannoma. Now, these tumors can have a lot of melanophages, as I told you, and can show intranuclear inclusions. They can show degenerative nuclear atypia, as you see here, or they can have very clearing of the cytoplasm, kind of resemble an adipocytic tumor. And as you know, they can have some homogeneous bodies. Now, they can have zero homogeneous bodies, they can have a few, or they can have a lot, as you see here. Now, I don't know if you remember from your medical school, you know, the dogma was the homogeneous melanotic schwannoma is associated with corneal complex, but we now know that is not correct. There is no clinical correlation between the number of homogeneous bodies and the relation of the tumor with corneal complex or sporadic. So it is a spectrum. Patients, sporadic melanotic schwannomas or melanotic schwannomas that are associated with corneal complex can have a various numbers of homogeneous bodies, so that's not indicative of anything. They can have various patterns. They can have a myxoid change, as you see here. They can have the so-called small cell pattern, or even they can have a ripple pattern resembling a neuroendocrine neoplasm. But again, if you put more sections, you're going to see more classic areas of spindle cells that you associated more commonly with melanotic schwannoma. They can invade the bone. And of course, as I told you, about 1/4 of the cases, they metastasize, and they can give distant metastasis most commonly in the lung. And this is a case of melanotic schwannoma metastasizing the lung. So you can imagine if you have no history and you get this tumor, and we're going to talk a little bit about our immunohistochemical profile, you can easily diagnose this as metastatic melanoma. Now, one thing that I want to draw your attention is that despite of what is out there, not all tumors are positive for S100. A small percentage of melanotic schwannoma, they're actually S100 negative. And of course, they're going to stain for melan A and HMB45. They have true melanocytic differentiation. And that goes against the name schwannoma, because schwannomas are always positive for S100. And of course, they're negative for melan A and HMB45. And that goes more with what we see in melanomas. Melanomas, occasionally, they can be S100 negative. And melanotic schwannomas, they are GFAP negative, which is in contrast to your conventional schwannoma, which 50% of the cases are GFAP positive. So that is one thing that you have to be aware, that even if it's S100 negative, it doesn't necessarily mean it's not a melanotic schwannoma. And this is another case of melanotic schwannoma resembling a melanoma. You can see an unencapsulated tumor composed of epithelioid cells. And of course, Fontana-Masson highlights the melanin granules. And of course, this tumor is diffusely positive for S100, SOX10, and melan A. But a small percentage, about 10 to 15% of cases, is probably less. Probably the paper has some tertiary referral center bias, but it can happen. HMB45 will be diffusely positive. And the other thing, I told you that the germline, the familial melanotic schwannomas can have mutations in the PRKAR1A, and that is true for the sporadic ones. And we have a stain that it doesn't correlate 100%, so it's not a perfect stain, but loss of PRKAR1A is a surrogate marker for a mutation of this gene, and it can be seen lost in melanotic schwannoma. It's not very helpful diagnostically in your differential that we're going to talk a little bit in the next few slides, but it's something that it can happen. Now, can we predict which patients are going to do well and which patients are going to develop metastasis? Which that's, you can imagine if a patient gets a diagnosis, that's a very important information that he or she would like to know. And the truth of the matter is that we actually cannot predict which patient is going to be they're going to behave bad, and it's pretty sad that we still don't have the tools to actually tell apart. There is tumors who have a mitotic activity more than 1/10. It was statistically significant in this large study that they're going to behave in an aggressive fashion. So if you see more than 1 mitosis per 10, you can start worrying. But there were half of the cases that the patients behaved aggressively, that the tumors behave aggressively, they actually had 0 mitotic activity. So it's really, even if you don't see any mitosis, it's really, you can't really say that this tumor is going to behave in a benign fashion. So we don't have the tools yet. It's a mystery, and there's a lot of work to be done to actually tell the patients or that they have these tumors if their tumor is going to behave aggressively or not. Now, melanotic schwannoma, it's not just a tumor of the deep soft tissues. It can rarely happen in the skin. It's very rare that it can happen. And of course, it can actually be misdiagnosed as melanoma or a pigmented epithelial melanocytoma or other tumors that we're going to talk a little bit. And this is an excellent review by the colleagues in University of San Francisco. It's very rare. There are only a bunch of cases, like 10 cases in the literature, but it can happen. So when it happens in the skin, it tends to arise in the trunk in about 6 to 7% of the cases. It has a largely equally gender distribution. And the cutaneous melanotic schwannomas, they can be associated with corneal complex as well in approximately 50% of the cases. So when we encounter this tumor in the skin, what is our differential diagnosis? First of all, one differential that comes into mind is melanotic neurofibroma. But melanotic neurofibromas will have small wavy spindle cells, and they will not have epithelial cells that you see in melanotic schwannoma. And of course, they're going to lack samoma bodies. The pigmented epithelial melanocytoma, which is a melanocytic tumor of intermediate malignancy, it has more melanophages and is less cellular than the samoma, than melanotic schwannoma. We're going to talk a little bit about that. Variants of blue nevi, there are in the differential, and the pigmented epithelial melanoma, which is a melanoma which is happened to have to be epithelioid and occasionally have samoma bodies. Now, samoma bodies in melanoma, it's actually pretty rare, but it can happen. So when you see samoma bodies, you really have to see the cytology very carefully and put all the factors in your analysis, because samoma bodies can be encountered occasionally in melanomas. It doesn't mean necessarily that it is a melanotic schwannoma. The reality is that there are not clearly individual clinical pathologic features that are completely specific to differentiate it between malignant melanotic nerve sheath tumor versus melanoma. You have to put all the data, clinical, histomorphological, protein expression, and molecular, into trying to make the best diagnosis. So melanotic schwannoma would be expected to be paravertebral. It's predominantly spindle, has heavy melanin pigmentation. You see samoma bodies, it has some, and the other clue that you start thinking about melanotic schwannoma, it's when you see striking nuclear pleomorphism. If it is a regular melanoma, you see mitosis very easily. But when you have a tumor that has true melanocytic differentiation, it is in the appropriate clinical scenario. It has a striking nuclear pleomorphism, but very low mitotic activity. Then you start thinking about melanotic schwannoma. And of course, a detailed clinical history and careful dermatologic investigation, it's a key. And people have looked at the gene expression profiling data, and clearly melanotic schwannoma clusters very differently from schwannoma that you see here in the green and melanoma you see here on the blue. So it's an entity on its own, which has melanocytic differentiation, but it has a very different expression profiling from melanoma and schwannoma. Now, occasionally, I told you that the PRK-AR1 stain is not very helpful in your differential, because melanomas and pigmented epithelial melanocytomas that are in the differential with melanotic schwannomas, they have mutations as well in the PRK-AR1A gene. And you can see that with the and this is a case of epithelioid pigmented, heavily pigmented epithelial melanoma, which shows loss of PRK-AR1A staining because of the underlying mutation, but it's not a melanotic schwannoma. So you have to be that aware. So people have looked at that, and these are truly melanocytic neoplasms and melanomas. And you see here that These have PRKAR1A mutations, but many of them, they have TERT mutations. They have deletions of the 9p21 locus. They have BRAF mutations or NRAS mutations, which you don't expect to see in melanotic schwannoma. So the molecular profiling of these tumors can actually be extremely helpful in very difficult cases to actually differentiate it between melanomas and melanotic schwannomas. The other tumor that is in the differential, it's the pigmented epithelial melanocytoma. This one is a truly melanocytic tumor of intermediate malignancy. And what is the definition of melanocytic neoplasms of intermediate malignancy? They go to the lymph nodes, but they don't give distant metastasis. So despite the fact that the sentinel node can be positive, they don't kill the patients. So a melanocytic tumor that goes to the sentinel node, it's not necessarily a melanoma. We know that the data are pretty clear. So you have to put things into perspective. So these tumors have PRKAR1A mutations as melanotic schwannomas, and actually they can show fusions of PRKCA genes. And this is a case that the differential would be melanoma or a epithelioid melanotic schwannoma, superficial one. But the clue here is that they have a more fried egg appearance, we call it. The cells are way more epithelioid, wall to wall, from a melanotic schwannoma, and it looks less cellular than the melanotic schwannoma. Have way more melanophages, and of course, if you see a background nevus, that will be very helpful. And these tumors, the pigmented epithelial melanocytoma, we know now that genetically they're being divided in two broad categories. The combined one, that they have a background nevus, as I showed you before in the previous picture, and these have a BRAF mutation. And what happens is that they get the second hit, they get a hit on the PRKA1A gene, and they transform morphologically to something that looks a pigmented epithelial melanocytoma, and you see in the background remnants of nevus. And then we have tumors that they are pure. We don't see background nevus, and these tumors, they have usually PRKC or PRKACB, etc., fusions. And melanomas with only fusions, they have not been described so far, at least. And of course, melanotic schwannomas will not expect to have PRKCA fusions. So one thing you can do if you're not sure if it is a melanoma or a melanotic schwannoma, one easy thing you can do in your lab is to do a BRAF or NRAS immuno. If that tumor is positive for BRAF or NRAS, then it's not a melanotic schwannoma. If it's negative, of course it could be, and you have to put all the things together. And of course, things are getting really complicated every other month. I just want to mention that pigmented epithelial melanocytoma is a different thing from melanocytic tumors of what we call of the blue category, like blue nevi, cellular blue nevi, melanoma X, blue nevus. They have the melanocytic tumors in the blue category, they have mutations in the GNAQ, GNA11, or more rarely in the CYSLTR2. But tumors with the CYSLTR2, when they get that, occasionally they can actually look like a pigmented epithelial melanocytoma, as you see on these pictures, but these are genetically on the blue category. And in the blue category, they can be completely benign, atypical, intermediate malignancy, or fully malignant. It's just something to just give you the complexity that sometimes you can't tell by the morphology, and you really need molecular analysis. The second tumor that it's a mesenchymal neoplasm, but has truly melanocytic differentiation, it can be misdiagnosed or with something different, is the so-called Pecoma that you're all familiar with. And it's a mesenchymal tumor that is composed of the so-called perivascular epithelioid cells, that it's a distinctive neoplastic cells that we don't know, doesn't have any known counterpart. And the characteristic of these tumors is that they show immunoreactivity for both melanocytic and smooth muscle markers. And that comprises a group of mesenchymal neoplasms that is the angiomyolipoma that you see around the kidney, clear cell sugar tumor of the lung and extrapulmonary sites, lymphangioliomyomatosis, clear cell myomelanocytic tumor of the falciform ligament and ligamentous teres. But occasionally, rarely, but it can happen, you can see that in the skin, you can actually have primary cutaneous Pecoma. And this is a nice paper that if you read the review, actually you're pretty set up, you're pretty updated on this entity. And we're going to show a few pictures, but briefly, the characteristic of this tumor has this proliferation of epithelioid cells. They are arranged in nests and trabeculae. We have these background delicate capillaries. And the very characteristic that Sharon Weiss taught me when I was her fellow is this very characteristic granular pink cytoplasm. When you see this granular pink cytoplasm, think about Pecoma. And it has a distinctive immunophenotype. It stains for melanocytic markers. I'm going to talk a little bit about this. HMB45 is the most sensitive, or smooth muscle markers. However, the caveat here is if you encounter a Pecoma in the skin, it's actually less likely to demonstrate immunoreactivity for smooth muscle. And that can be a total pitfall. And actually, I had a recent consult. They actually thought it was Pecoma, but they say, well, it stains from melanocytics, but it doesn't stain for smooth muscle markers. It was a primary cutaneous Pecoma. So that make them a bit uncomfortable if they're missing something truly, a melanocytic tumor, but it was actually a Pecoma. It has a very characteristic cytology. And this is a very characteristic cytology. You have these monotonous epithelioid cells organized in a trabecular pattern with these intermingled thin capillaries and this abundant clear to granular cytoplasm. It's very characteristic, and you should think about that when you see that cytology. The tumors can be very infiltrative. You see here, this tumor infiltrates from the mid-dermis down to the subcutis, and again has this granular eosinophilic cytoplasm, and you can think about histiocytes maybe, or something along these lines. And again, this trabecular growth pattern with these interspersed capillaries kind of resemble a clear cell renal cell carcinoma, if I may, but this is a Pecoma. And this tumor stains for melanocytic markers, HMB45 or melan A. HMB45 is the most sensitive one. It can be focally, multifocal, or negative for myomarkers. And this particular case was positive for this. And this is an excellent paper from folks in University of San Francisco that you see here that desmin, specifically in the cutaneous Pecomas, it was negative, and SMA was only focally positive. And the other thing is about CD68, because these tumors kind of resemble histiocytes. CD68 is not a specific stain whatsoever. What it does is actually stains lysosomes. So any tumor who has a lot of lysosomes will be positive for CD68. I use PU1. That's an excellent, more specific histiocytic marker. It's a nuclear marker. It works perfect. You can, in every lab that I've seen, it works perfect. So I suggest for histiocytic marker to bring in your lab the PU1 and just forget about the CD68, which can create a lot of problems. And again, the most sensitive marker is the HMB45. 94% specificity, as you see here in the cutaneous one. The myomarkers can be in a significant proportion of cells completely negative. This is a case that was actually misdiagnosed as melanoma, and actually it's a cutaneous Pecoma, and occasionally these tumors can have, they have melanocytic differentiation. Occasionally you can see actually melanin very easily. It was melanin, of course, has some hemosiderin stain with a pearl stain, but this is melanin stain for Fontana. And you can see here how this tumor, if you don't think about it, can actually be misdiagnosed as melanoma, because this tumor was diffusely positive for HMB45, and of course it was negative for other markers, including SMA. But these tumors are SOX10 negative as well, right? I've seen melanomas, I've seen dedifferentiated melanomas, which are completely negative for everything. I've seen melanomas are S100 negative, SOX10 positive. I've never seen a melanoma which is S100 positive, SOX10 negative. I've never seen that. Just to be just to put there in. And for people who's practicing many years, you know, in the old days, they're using CD10 to differentiate it from renal cell carcinoma. Of course, is a completely non-specific stain that I only use it in two scenarios. I use it when I see a uterine sarcoma, you know, a low-grade endometrial stroma sarcoma, and I use it when I see a hematolymphoid in cutaneous. I don't do hempath. I do hempath in cutaneous hempath, you know, with primary follicle central lymphomas. You just want to highlight the follicle centers. And the new thing is this cutaneous fibroma-like Pecoma. That's kind of interesting. It really looks like nothing. It looks like a fibroma. It's how many of you have to think about that. And these tumors actually, they are positive for HMB45 and desmin. And the classic cutaneous Pecomas that I show you in the previous slides, they're not associated with tuberous sclerosis. But the cutaneous fibroma-like, which is very recent, and we don't have a lot of cases, all the cases that actually were published on this paper, they actually were associated with tuberous sclerosis. So that's kind of important. So if you have something that you diagnose as fibroma-like cutaneous Pecoma, you have to put a comment to actually check the patient for tuberous sclerosis, or the other way around. If you have a patient with tuberous sclerosis and you see something that looks like fibroma, looks like nothing, think about fibroma like cutaneous Pecoma. But the classic Pecoma that I showed you before, it's not associated with tuberous sclerosis, and you should not put a comment because it will alarm falsely the clinician and the patient. Now, we have done quite a work about the genetic background of Pecomas, and we now know there is a dichotomy. Half of the Pecomas, they show TSA2 or TSC1 mutations, and then the other ones, almost half of it, there's some that we don't know yet. They have translocations. Most of them, they have TFE3 translocations. They have a very specific morphology, but not always. And primary cutaneous Pecomas with TFA3 rearrangements have not been reported so far. And of course, you have other genes that they are fused. And so what is your differential when you get a cutaneous Pecoma? I mean, you can think about balloon cell Nevus. You can think about clear cell melanoma. You can think about clear cell sarcoma, but clear cell sarcoma would be diffusely and strongly positive for S100 or SOX10, where cutaneous Pecomas are expected to be negative. It could be the so-called dermal clear mesenchymal neoplasm, which nobody knows what it is. It's something that's out there. And of course, it can be a metastatic clear cell carcinoma. But of course, clear cell carcinoma will be positive for keratins and PAX8 and negative for melanocytic markers, except that you have to know, you already know that we have translocation, XP11 translocation renal cell carcinomas that there are show melanocytic differentiation. But of course, these tumors are PAX8 positive and keratin positive. So this is a nice cocktail to do to cover all your differential, to do an S100 and SOX10, do a melanoma, HMB45, SMA, and desmin, and that will, you know, if you are in that differential, that actually it's a pretty decent stains to do to actually try to figure it out. Now, Pecomas, they have been studied pretty extensively in terms of histologic criteria where can predict which ones are going to behave aggressively and which are not. And this was done by Andrew Fulp and Sean Wise, my former mentor, quite a few years ago. And you know, if the Pecoma doesn't have any worrisome features, less than 5 centimeter, non-infiltrative, et cetera, they behave in a benign fashion. But if you have 2 or more, big size, infiltrative, high nucleograde, cellularity, high mitotic, more than 1/50, necrosis or vascular invasion, we call them malignant. And if they have one worrisome feature, we call them a certain malignant potential. So these were studied in Pecomas of deep soft tissue and gynecological origin. We don't have a lot of data for the cutaneous one, but there are Pecomas, malignant Pecomas that are truly cutaneous, that they have behaved in aggressive fashion. There are only 7 cases reported. Some of them, that nothing happened to them. Some of them metastasized. And this was a case that you can imagine, if you don't think about it, this, you can call this as some kind of sarcoma. Actually, this was a malignant Pecoma with TSC2 mutation, and it's something to think about and do the appropriate stains. And of course, if you get a malignant Pecoma in the skin, they're very rare. So your first thing you have to think is, could this be a cutaneous met from somewhere else? And this was a remarkable case that this patient was misdiagnosed, had a uterine tumor that was misdiagnosed as the leiomyosarcoma. Then it gave a brain metastasis that it was, I don't know if the patients didn't, they didn't have the previous history, and it was misdiagnosed as a metastatic melanoma. So it had 2 different diagnoses. And when they got the cutaneous met, they finally figured it out. And this was a malignant Pecoma of the uterus that had given metastasis to the brain and the skin. So extraordinary stuff, but it can happen. So before you diagnose a primary cutaneous Pecoma, think about a malignant Pecoma of a visceral malignant Pecoma. We see that relatively commonly in the uterus, in the GYN world, that has given a metastasis. Now, things get even more complicated as we do more molecular. Now, this is a peculiar tumor that looks like Pecoma, has this clear cell, this trabecular growth pattern. It's positive for HMB45, it's negative for SMA, but I told you this can happen. But it's unusually diffusely positive for S100, which is not expected to see that in Pecoma. So it could be a completely different entity, and this have a recurrent translocation involving the actin and MITF genes. So they have a fusion between the active and MITF. As you know, MITF is the master regulator of melanin synthesis. And what happens is when you get a fusion with the actin gene, that leads to a hyperactivity of the MITF function, the same way that you see that with fusions of TFE3 or TFEB. It's kind of the same mechanism. That's why you get this melanocytic differentiation, because the master regulator of melanin synthesis was hijacked because of the fusion. And all these cases were diffuse S100, so they don't fit very well for Pecoma, although they look like Pecoma, and they all have this recurrent translocation. So it may actually be a novel entity that has reproducible immunohistochemical and histomorphological findings. Clear cell sarcoma was described by my mentor's mentor, Dr. Enziger, who was Sharon White's mentor back in 1965. And he actually noticed the Fontana positive pigment, which is melanin pigment, but he disregarded, he was mistaken at that time, as a potential diagnostic pitfall. It didn't click to him that actually could be a clue of the differentiation of this tumor. So 20 years passed, and in 1983, Enziger and Chung proposed the term malignant melanoma of soft parts, because Hoffman and Carter, doing electron microscopy, they actually identified melanosomes, which showed that this tumor has true melanocytic differentiation. So they proposed malignant melanotic of soft parts, which was a mistake as well, because we know now that clear cell sarcoma is not a melanoma. So now we call it clear cell sarcoma, although there is some debate if it's actually a melanoma, but I'm not going to go into that. So clear cell sarcoma can happen in middle age to young individuals, and usually happens in deep soft tissues of the foot and ankle, and frequently involves tendons or aponeurosis. But we can have truly primary cutaneous clear cell sarcomas. And usually these tumors are small. They're less than 5 centimeters. The primary cutaneous are less than 1 centimeter, but otherwise I have similar clinical and pathologic features. And the natural history of these tumors, they're protracted, they have multiple local recurrences, and they give metastasis to lymph nodes, lung, and bone. Now, these patients are treated with wide local excision, and adjuvant radiation. And it can really look like melanoma when you actually pay attention to individual cells that have this cherry red nucleoli, the stain for melanocytic markers. But I want you to take a step back, and I'll give you a clue that we use a lot in soft tissue pathology. Sarcomas are being divided into two broad categories. One category is the sarcomas who have a very complex genome. They have the genome is all over the place. They have gains and losses, chymotrypsis, they get a lot. It's very complex. And these tumors, they look very pleomorphic, and they compose approximately 70% of sarcomas. And then we have the sarcomas that they have a quiet genome. They are being defined by translocation, a fusion, which is the driver, which gives all hallmarks of cancer, and they will get this sarcoma. These sarcomas, if you actually see SNP arrays, they have a very quiet genome, that they have only the fusion, and they look very monomorphous. So this tumor, to me, it looks quite monomorphous, and it would be very unusual for a melanoma of that side to be that monomorphous. So that is a morphological clue. If you see something that is mesenchymal, or you don't think it's mesenchymal or melanocytic and looks very uniform, think about a translocation associated tumor, that being a mesenchymal tumor or a carcinoma or whatever that is. Because this tumor otherwise shows diffuse positivity for S100, SOX10, melanate, it really stains like melanoma. And to get things even more complicated, it can show, what do we do as a dermatopathology when we see a tumor that is melanocytic? And we don't know if it's a metastasis, the primary. We actually go to the dermal-epidermal junction to see if there is any activity. If there is an activity there, we say, okay, this is a primary melanocytic lesion because it has a dermal-epidermal activity. However, you can have colonization of the dermal-epidermal junction in various tumors, including clear cell sarcoma, resembling a primary melanocytic tumor. And this was a very unfortunate case that not only it was not called clear cell sarcoma, it was actually called Spitz-Nevus because it was looking very spitzy, and because they thought it was a primary tumor because of the colonization. That was a compound clear cell sarcoma, which after a few years, it showed, it gave a very dreadful bulky metastasis to the lymph nodes. Usually sarcomas, they don't go to the lymph nodes, they go to the lungs, as you know, but there's a handful of sarcomas, including clear cell sarcoma, that actually metastasizes to the lymph nodes. So you can have that. And this one, to make things even more extreme, if they're not extreme already, this, believe it or not, is actually a metastatic clear cell sarcoma with epidermal colonization. We know that can happen in melanomas. Melanomas can metastasize and show epidermal colonization resembling a primary melanoma, but apparently this can happen in clear cell sarcomas as well. There are ways to differentiate it from melanoma, easy way if you think about it. And we know clear cell sarcoma is a fusion sarcoma, which shows EWSR1 in the majority of the cases, ATF1 or EWSR1 CREB1. So you can do the FISH, or you can do NGS to actually see if there is a translocation. And we now know that it has another partner in rare cases. It's called CREM. It doesn't come as a surprise because CREM belongs to the same family of transcription factors with ATF1 and CREB1, which is called CREB family of transcription factors. And these tumors, they look exactly identical. So if you just do the FISH for EWSR1, you're done. The partner doesn't matter, but you have to know, and we're going to talk a little bit about that EWSR1 is one of the most promiscuous genes that you will encounter in human neoplasia, and it can be seen in gazillion different tumors. So you have to put everything in perspective. But in terms of your differential with melanoma, no melanoma has been described that shows EWSR1 rearrangement. So I had the honor to be part of the task force committee of the American Society of Dermatopathology, where we actually try for the first time put out in the community appropriate use criteria, when it's appropriate to actually use molecular studies or immuno for specific entities. And the entities that we actually study the literature, it was clear cell sarcoma and DFSP. So we put actual criteria when it's proper to study them. And then one thing that you have to be aware is very rare that sometimes there are genuine clear cell sarcomas that are molecularly confirmed that very, very rarely can actually show BRAF mutation, which is common in melanomas. So that is not going to save you. So BRAF positivity, if it's positive, the odds is that it's melanoma, but it's not 1,000%. Extremely rarely you can have genuine clear cell sarcomas that are BRAF mutated. And the other thing is you have to be really careful where you do your EWSR1, because EWSR1 FISH can have a lot of atypical patterns that if the lab is not experienced, whoever interprets the FISH is not experienced, it can actually misinterpret. And I had cases that with the FISH, it was misinterpreted, but there was no way that was what, you have to put everything, you don't blindly believe everything you get because there are false positives and false negative. So EWSR1 occasionally can give you funny patterns that can be misinterpreted by someone who's not very experienced in reading FISH slides. What is your differential? Melanoma, we talked about. Pecoma would be negative for S100 or SOX10, so that would be easy to solve. And then the classic differential is with cellular blue nevus, and the new thing is with cutaneous melanocytic tumors with CRTC1 TRIM11 fusion, which is pretty exciting. So this is your classic cellular blue nevus. The cells, they have this dumbbell shaped in the deep dermis. The cells look more bland. You don't have mitosis, necrosis, but of course you can have melanoma arising in the background of nevus, and they can look pretty atypical, but this usually looks more pleomorphic than your clear cell sarcoma. And of course, if you see background cellular blue nevus or sclerotic blue nevus, that will be easily solvable. In very difficult situations, melanoma X blue nevus is positive for GNA11 or GNAQ mutations, as I told you before, whereas melanoma, where clear cell sarcoma will show EWSR1 rearrangements, whereas blue nevus, it's negative for EWSR1 rearrangement. But one other big differential, which it's actually very important to differentiate it because it seems to have a different natural behavior, is with this new thing called cutaneous melanocytoma with CRTC1 TRIM11 fusion. Now, for reasons that I will explain to you in the next few slides, we don't use the term melanocytoma. We better use the term cutaneous melanocytic tumor with CRTC1 TRIM11 because melanocytoma, as I told you, implies that it has a indolent behavior, where this tumor, we know that it may not have that indolent behavior, as I show you in the next slide. So this, I understand why people misdiagnose this as a primary dermal melanoma or as a clear cell sarcoma. It can look very spindle, kind of looks like clear cell sarcoma, but this tumor has a different fusion. And this is the immunohistochemistry, which shows hyperactivity, nuclear expression, but it can look, has a little bit different. This tumor had necrosis, look more epithelioid, a little bit more pleomorphic than you'd expect in your classic clear cell sarcoma. Here it looks different to me than a clear cell sarcoma. I could misinterpret this as melanoma for sure. A primary dermal melanoma which may not exist. And this case is a case of CRTC TRIM11 fusion. Is diffuse laser positive and can express melanate, can express HMB45. For some reason, expresses NTRK1. It doesn't have any rearrangements of NTRK, so it has a hyper expression of NTRK protein for mechanism other than rearrangement or amplification. We don't know actually why. And one thing that doesn't fit with melanoma is, first of all, they don't have BRAF or NRAS mutation. Okay, that can happen with melanomas. But this pattern on SNP array, this is actually, you see all the chromosomes, 1, 2, 3, 4, 5, etc. When it goes up, it shows gain. When it goes down, you have losses. So in melanoma, you have multiple gain or losses. The genome doesn't look that quiet. So that goes against melanoma. And of course, the first paper, they didn't have any local recurrence or metastatic, but it was a very short follow-up. So that is very important, because then they discover a patient who gave a metastasis after 13 years. Of course, we didn't know that it was a CRTC1 TRIM11 30 years ago. It was a patient from Africa who was treated there, and then went to France. And of course, they got the metastasis, and then they analyzed the metastasis and turned out to be a CRTC11 TRIM11. So the French groups, they say, well, this is probably a clear cell sarcoma with a novel fusion. Nobody agrees with that. We don't think that's not the case. It's very early to say, but this is the proof that tells you for tumors, you really need very, very long follow-up before calling something melanocytoma, which implies a very indolent behavior. This, if you don't do nothing, it can actually behave pretty aggressively, hence the term clear cell tumor with CRTC1 TRIM11 fusion. And this was the case. And if you got that metastasis and you didn't have any molecular, you didn't have access, you didn't think about it, the most reasonable thing to do is you have called that metastatic melanoma of unknown primary. I mean, that was probably, but this is a CRTC11 TRIM11. So you can see how the molecular revolution is actually helping us to some extent actually make more accurate diagnosis in difficult cases. You don't need them in the, in the great majority of cases, but there are cases like these that molecular will save the day. So, and that was very fascinating. I had a case back in, this paper came out in 2016, right? I had this case in 2016. The paper came out in 2018. I had this case, and I stained it, and I'll show you it was stained for SOC-STAN, for a little bit from melanocytic markers, etc. I couldn't call this melanoma. It was the back of an old lady with no history of melanoma. I didn't know what it is. I sent it to, I was in Durham at that time. I sent it to Memorial. The DermPath saw that, the soft tissue saw that they didn't know what it is. Nobody knew what it is, which is good because it's not ideal to start to squeeze entities you're not quite sure in specific boxes because they may not fit in that boxes. So we were descriptive and we're really excited. So about that case, I kept this case in my mind. So when I saw that paper 2 years later, I have this instinct that say this got to be that entity. So I went back to this case and I analyzed the molecular, and it was indeed a CRTC1 TRIM11 fusion tumor, and we put it together with another entity from University of Arkansas, and we did a literature review. And you can see that these tumors, they're not all melanate positive or HMB45. You can have cases that are negative. And you can have cases that are negative for S100, but they're all positive for SOC-STAN. I always do both SOC-STAN and S100 together because sometimes S100 can be negative. So it's very helpful to do actually both. And I got really excited, and we actually wrote a very recent review about this entity. That you can, it's free access. You can download if you want. You can read about this entity. It's actually pretty exciting. And this is a tumor, this was from Sharon Weiss, that it's actually amazing because she called that paraganglioma-like dermal melanocytic tumor. She was such a great morphologist that she said, I can't call it, looks different. It looks different from cellular blue nevus, clear cell sarcoma, cutaneous melanoma. It kind of, you could squeeze it to one of these three entities, but it would not be truthful. She would not be honest. It looks something different. So she called it that. And I bet you some of them are CRTC1 TRIM11. So out of them, there may be the MITF acting, like this tumor here. I actually contact her and ask her for material. And she sent me some of that stuff. Many of them, this paper is like 20 years ago. We didn't have all the material. I got the blogs, but many, because it was so old, the RNA-seq failed. I just wasn't successful. But I think what she called at that time as something different, I think she was correct. And some of them are CRTC11, TRIM11, MITF, etc. It's always a nice satisfaction when you go back to these papers and you can actually refine the classification with the current knowledge. And of course, things get even more complicated. And there is something that resembles a Pecoma, but actually this tumor shows MITF cramp fusion. And this fusion is actually and is diffusely positive for S100, SOX10, melanate, MITF, and based on the molecular of this fusion, it actually is probably closer to clear cell sarcoma because that fusion, the MITF CREM, appears to be analogous to EWSR1, ATF1, and EWSR1 CREP1. Now, you all know about PRAME. We use that PRAME to distinguish between melanoma and melanocytic nevus, right? It was very promising. Now we know it's okay. It can be very helpful when it is, and it can be not helpful when it's not helpful. So it has about 60% sensitivity and quite high specificity in terms of differentiation between melanoma and melanocytic. So people have looked at that in terms of tumor with melanocytic differentiation, and you will see here that clear cell sarcomas were negative for PRAME. PRAME is considered positivity when it's 3+ and above. And almost all of the Pecomas are negative, except there was one Pecoma that it was positive. So the 3 clear cell sarcomas were negative, and then there was another paper who had about 10 cases of clear cell sarcomas, and they were all negative for PRAME. And this is a case of melanoma, was positive. So if you have a differential, it's a surrogate marker. I mean, you have to do molecular, but if you have a clear cell, it's probably, you're not sure if a clear cell sarcoma is PRAME positive, it's probably not a clear cell sarcoma. What is more exciting is that how that fits so nicely with basic science. And this is knowledge that we have 20 years ago. And actually what we actually discovered now in terms of clear cell sarcoma and negative PRAME, it actually makes sense because these were actually expression profiling studies of clear cell sarcoma cell lines. And one of the most down-regulated genes, was 38 that was significant, their expression was significantly down-regulated. One of them was actually PRAME. So it makes total sense why you see these clear cell sarcomas to be negative for PRAME. And that is like, it's such a nice, tight correlation with basic science data and what we see in the immunohistochemical level and how that can help us in the differential with melanoma. Clear cell sarcoma, tumor of the GI tract. Now I'm going to switch to tumors that they can be SOX10 and S100 positive. They don't show truly melanocytic differentiation, but it can be actually resemble and misdiagnose as melanoma. So it has morphologic similarities with clear cell sarcoma, but the difference here is it shows the same fusions, but most commonly shows the AWSR1 CREP1 and less commonly the AWSR1 ATF1, which is the opposite in clear cell sarcoma. And you all have seen that if you do GI pathology, whatever, it's more common. And this is a GNET, gastrointestinal neuroectodermal tumor. You see here very epithelioid, very nested appearance. It can look like melanoma. In the past, melanomas can metastasize to the small bowel. It's not infrequent. So these were called in the old days metastatic melanoma of unknown primary. And you have this nested appearance. You can show lymphovascular invasion very characteristically, and that is a clue that show this pseudopapillary architecture. That is a clue if you see a neoplasm in the GI tract that is S100 SOX10 and show this pseudopapillary architecture. It's a clue to think about clear cell sarcoma of the GI tract or gastrointestinal neuroectodermal tumor. It can show multinuclear giant cells, as you can see in the clear cell sarcoma as well, rosettes, or it can be very spindle, but if you put a lot of sections, you'll see more commonly this pseudopapillary configuration. These tumors are positive for S100, they're positive for SOX10, but they're consistently negative for more specific melanocytic markers, and they're negative for synaptophysin, and they can be positive for CD56 if you do it. I don't do it, it's not a very specific marker. But if you do it, they can be positive. That is the immunohistochemical profile. And SOX10, of course, so that's why they were misdiagnosed as melanomas. But of course, we know now it's a different entity. It's not a clear cell sarcoma. So the term that is proposed to be used is malignant gastrointestinal neuroectodermal tumor, or so-called GNET. However, very rarely, almost in 99% of the cases, you're going to see them in the GI tract, but very rarely you have to be aware that the GNET you can actually see that in entities in areas outside the GI tract. And this is a case from the tongue. They are extremely rare. You can see them in the oropharynx. So you have to be aware of that. So if you see something SOX10, S100 positive, it's negative for melanocytic markers, think about extra gastrointestinal neuroectodermal tumor and do the molecular. The other thing, melanoma, I want to just as a clue, melanomas can, of course, lose melanocytic markers, but it's very unusual for melanoma which is epithelioid to be negative for melanocytic markers. When melanomas lose their more specific melanocytic markers is when they get more spindle. But I talked about molecular, but I'm primarily a morphologist, and everything starts from morphology. I love molecular, but I have to admit everything ends in morphology and context, because we now know that all these fusions are promiscuous. Exactly the same, not just one gene, both of genes, exactly the same gene, like AWSR1, CREB1, or ATF1, can be seen in clear cell sarcoma, GNET, pulmonary primary myxoid sarcoma, in a carcinoma, hyalinizing clear cell carcinoma, myepithelial tumors, angiomatoid fibrous histiocytoma, mesothelioma, clear cell odontogenic carcinoma, and other tumors. So it just gives you the promiscuity that you have to put everything together to make the appropriate diagnosis. Another tumor that can actually show pigmented cells is, of course, DFSP. DFSP can have these intermingled melanin-bearing dendritic cells, and that historically is known as Bednar tumor. And of course, it's going to be CD34 positive, and you can get the molecular. It's easy to diagnose this. A very rare tumor, which can create a lot of anxiety to clinicians and parents, is this very rare tumor called melanotic neuroectodermal tumor of infants, because it grows very rapidly. The children, they are infants, they're less than 1 year old, that's most common, and predominantly involves the craniofacial sides, and classically has this biphasic population. You have these more epithelioid melanocytic cells, and then you have these primitive neuroectodermal cells that they look more like neuroblastoma. So you have these cells that they look more melanocytic, you see the melanin, and then you have cells that they look more primitive, resembling a neuroblastoma or neuroblast-like. And this tumor is positive for cytokeratin, it's positive for melanocytic markers. So it can create anxiety. We don't really understand this tumor very well. It has a high risk of local recurrence, but this is presumably because of multicentric growth pattern and incomplete surgical excision rather than anything else. Now, if you want to diagnose an MPNST in the skin, think 99% of the cases you're going to be wrong. It's going to be melanoma. It's extremely rare to have a primary spindle MPNST, but it can happen. And in contrast to their deep soft tissue and visceral counterparts, it is rarely associated with neurofibromatosis 1, and it's being categorized in two main subtypes: the conventional spindle and then epithelioid. And I want to focus on the epithelioid, but before that, I'm just going to give a couple of pictures of the conventional. This is a conventional MPNST. This is a low grade. Then you have a more cellular, hypercellular, which is a high-grade MPNST, and MPNSTs are negative for S100 SOX10 in half of the cases, or they're focal or multifocal. If you have something you want to call primary spindle MPNST, which is diffusely S100, is melanoma. It's not a spindle cell MPNST. But the epithelioid MPNST, it's a very different story. Epithelioid MPNST can happen deeply and subcutaneously, so you can see it in superficial and deep. And epithelial MPNST can actually be misdiagnosed as melanoma because it looks very epithelioid. It has this multilobulated appearance, although it's obviously malignant. It looks quite uniform, it has prominent nucleoli with vesicular nuclear pattern, but it's obviously malignant, multiple mitosis, typical mitosis, but it's in contrast to the spindle conventional MPNST, it's diffusely S100 positive. But it is negative for melanocytic markers. So the clue that I just told you applies here. A melanoma who looks that epithelioid would be very unusual to be melanate negative. That's one clue. And the other thing is that about half of the cases, 6% of the cases, they show INI1 loss, which has never been reported in melanoma. Melanomas can have INI1 mutations, but to lose protein expression has not been described so far. So that can be extremely helpful for the cases that lose INI1. There are cases that they have retention of INI1, so that really takes a lot of experience, clinical correlation, and perhaps an expert consultation to try to figure it out. And molecular perhaps in some cases. And this is a case I had as a dermpath fellow when I was in Indiana, where this tumor, it was on the back of a young woman who had been misdiagnosed in a very prestigious center, not Memorial Sloan Kettering, but in another prestigious center, but they had been seen only by dermatopathologists, which they don't have a very deep knowledge of mesenchymal neoplasia, because understandably, because there's just so much stuff. So it has been called as a primary dermal, it has been called as a metastasis stage 4 melanoma. So we got this, and I just want to give you a couple of clues. One clue for primary epithelioid MPNST is this multilobulation. This multilobulation would be very unusual for melanoma. And of course, then looks quite uniform. That is be very unusual for a melanoma, a metastatic melanoma of that size. So, and it was negative for melanocytic markers. It was positive for SOX10. And of course, then we do INI1 and it showed loss. And INI1, you assess loss of nuclear expression. So every time you assess an immunohistochemical stain for loss of expression, you really want to see a good internal positive control to make sure that actually the stain works. And this stain works very nicely because it highlights the background inflammatory cells. But to make things more complicated, one of the differential of epithelial MPNST is epithelioid schwannomas. And epithelioid schwannomas, the great majority of them, they happen superficially. And epithelioid schwannomas, they look bland. They have this epithelioid morphology. They have this perineural capsule that has been highlighted by EMA. And they can have this multilobulated growth pattern with a myxoid background, but they look very bland. They stain diffusely positive for S100, and SOX10, of course, are negative for more specific melanocytic markers. But epithelial schwannomas can do two things. First of all, they can have degenerative type of atypia, as you see here, as any schwannoma can have, schwannomas with ancient atypia you are familiar with. But extremely rarely, you can have epithelioid MPNST arising in the background of epithelioid schwannoma, like the case I show you here, obviously malignant features and obviously malignant cytological features. And epithelioid schwannomas can show as well in about 40% of the cases INI1 loss. So if your differential diagnosis is between epithelioid MPNST versus epithelioid schwannoma, or epithelioid MPNST versus epithelioid MPNST arising epithelioid schwannoma, then malignant versus malignant, malignant versus benign, INI1 is not going to help you. So there's no reason to do it. But if your differential is malignant versus malignant, and specifically between epithelioid MPNST and melanoma, then INI1 is extremely helpful. Melanocytic differentiation can actually be shown in non-pigmented diffuse neurofibromas quite a lot. As you see here, this was a diffuse neurofibroma with a lot of melanin. And of course, your differential here would be, is this a neurofibroma like melanoma, or is this a completely neurotized melanocytic nevus? So you have to see a background nevus for the latter. And of course, it will be pretty atypical if it is a neurofibroma like melanoma. So you have to be aware that neurofibromas, especially diffuse neurofibromas, can show melanocytic differentiation, can have a lot of melanate, but that is okay. You're not missing anything. And again, more cases of melanocytic neurofibroma. And I'm going to close with a couple of oddities. Plex for melanocytic schwannoma. This is different from Plex for melanocytic schwannoma, right? From melanotic schwannoma. plex from melanocytic schwannoma is something that looks like schwannoma, right? But schwannoma in the skin, it's pretty uncommon. And when you do the stain, it stains S100, but also it stains like schwannoma, like laminin, you see the basement membrane, but also it stains for melanA and MITF. We don't expect that in melanoma. And that actually makes embryological sense, because there is a subset of melanocytes that they develop from Schwannian precursors that they detach from developing nerves during normal development. So it makes total sense to have a potential biological mechanism where melanocytic nevi, they have Schwannian differentiation, or you can have tumors that they have two developmental pathways in parallel, one that exhibits Schwannian differentiation and one that exhibits melanocytic differentiation. See, so it's not crazy. It makes actually total sense from the embryological, but it's very, very rare. And then there is something that has been described in the literature as cutaneous melanocytoneuroma. Again, it looks very epithelioid. It looks like plant, and you do the stains and it's positive for S100, but it's also positive for melanA, but it's also stains for collagen 4 like you'd expect in nerve tumors. And this is an oddity that has been described in the literature. I think that's an exciting kind of subject. So I put it together and this paper just got published. It doesn't cover all the entities because it was for the dermatopathology journal, not for the soft tissue journal. I cover entities that they were more related to dermatopathologists. So it doesn't cover, but it covers the main entities if you want to read more about it. So we put it together. And I can send it to you, or you can find it in JCP. I'm happy to do that. That is my email. If you want to contact me, it's my Twitter account. I put I'll put medical stuff there. And I have a YouTube channel that I actually upload all my lectures for our pathologists around the globe can have access, and maybe somebody found them useful, I don't know. But I put them up there. And thank you very much.
Thank you so much, Dr. That was amazing. That was just, I know my residents are probably already on the YouTube channel right now. So wonderful, wonderful material. If anyone has any questions, please feel free to unmute now, or you can use the chat and I can read the questions if you prefer that.
Thank you, Dr. Fife, for hosting. This is Peter Lewis, resident at Rutgers, and thank you, Dr. Leos, for the masterclass in cutaneous tumors. I have a couple questions. Don't want to be in left field without a left glove. It's nuclear pathology and IHC. So, with respect to tumor burden, and correlation to PD-L1, why is it so much that melanoma and tumor mutational burden serves as a better prognostic marker for say other tumors?
Your voice is breaking.
But yeah, we're having trouble hearing you, Peter. Do you want to type?
Hello?
We're having trouble hearing you.
Oh, it looks like he just dropped off. Maybe he'll come back on and can type in the chat.
Yeah, maybe type it, Peter, if you're hearing us. Anyone else, please feel free to try to chat or to unmute. Maybe we'll give Dr. Lewis a chance to re-get on.
I just got back on. I apologize, lost connection. I'm not sure at what point I cut out. But my question was basically the relationship between tumor mutational burden, PD-L1, and IHCs. Why is it that tumor mutational burden is correctly a better prognostic marker in melanomas with respect to targeted treatments than say other cancers.
You mean that the melanomas with high tumor mutation burden, they have better prognosis with melanomas with low mutational burden, or
No, versus other tumors in general. Like, why is it the TMB? Because other tumors have high TMB, but for example, when it comes to gynecological tumors, but those the high TMB does not serve as a good prognostic, as a good predictive marker.
I'm not familiar if the melanomas with many of the melanomas, they are UV related, so they're going to have tumor mutation burden, high tumor mutation burden anyway. I don't know if we can say that the melanomas with high tumor mutation burden, they're going to behave. I don't know how you can compare the melanomas with the other tumors that are not melanomas in terms of the tumor mutation burden, right?
Okay, right.
It's just like comparing, you don't compare apples with apples or oranges with oranges. It's like comparing oranges with apples. So I don't have a good explanation, a good answer why the melanomas who have high mutation burden will behave better than other tumors who have low mutation burden. They're not comparable.
Okay, very good. And my last question, do you have as many YouTube followers as Dr. Gardner?
No way.
All right, thank you.
Anyone else? If not, I'll thank Dr. Linos again for an absolute tour de force. I'll recommend, I'm going to get on the YouTube this weekend for sure. I'm very interested, and I want to thank everyone who attended, and I can't thank you enough again, Dr. Linos.
Well, thank you very much for the invitation. It was a pleasure.
We have to have you back to do a slide session in another couple of years when there's 8 billion more mutations and fusions. Then thank you, everyone.
Thank you. Bye.
And enjoy your summer, everyone. Thank you.
Thank you, everyone. Have a good night.
Thanks. Good night.
Thanks, Chris. Bye.
Bye-bye.